contraception. Today we are going to discuss amenorrhea, its types and their causes. There are two types of amenorrhea: primary amenorrhea and secondary amenorrhea. Primary amenorrhea means she has never had menses before, and secondary amenorrhea, the female had amenorrhea, but then there's absence of menstruation. So we are going to discuss the causes of primary and secondary amenorrhea one by one. So primary amenorrhea can be caused by imperforate hymen, transverse vaginal septum, in other words, outflow obstruction, outflow tract obstruction such as imperforate hymen or transverse vaginal septum can cause primary amenorrhea. The second cause of the third cause of primary amenorrhea is absence of uterus or absent uterus, and the fourth one is Turner syndrome, in which there are no ovaries, either no ovaries or either ovarian failure. Any of them can be present in the Turner syndrome. So absent uterus can cause primary amenorrhea. Absent ovaries can cause primary amenorrhea, such as in Turner syndrome. Outflow tract obstruction can cause primary amenorrhea. Outflow tract obstruction is caused by imperforate hymen and transverse vaginal septum. And another cause of primary amenorrhea can be congenital adrenal hyperplasia. So these five causes are important to remember that can cause primary amenorrhea. So now how to differentiate between these causes? First of all, we will discuss how a patient of outflow tract obstruction will present to you. So a patient with primary amenorrhea plus cyclical pain, the pain that is associated, that is cyclical, and on ultrasound examination, there's a mass at lower abdomen. So primary amenorrhea with cyclical pain and a mass at lower abdomen, the cause is most likely hematometra. What is hematometra? Hematometra is accumulation of blood within the uterus. So why would blood accumulate within the uterus? Blood would accumulate within the uterus due to two reasons. Can you hear me now? Is everyone able to hear me?
Yes.
Yes, we are, but it's a little slow, I think.
Is there any voice distortion?
No, not as
No,
now.
there's no distortion, but in between suddenly it gets very slow and then it gets very. Otherwise, I mean, it's all right.
Okay. So a female with cyclical pain you will suspect uh, imperforate hymen and transverse vaginal septum, which will lead to accumulation of blood within the uterus. And on ultrasound examination, there will be a mass in lower abdomen, and your diagnosis will be hematometra due to imperforate hymen or transverse vaginal septum. So if the same female present to you with primary amenorrhea and there's no history of cyclical pain and ultrasound shows no uterus, then your diagnosis will be Mullerian agenesis or absent uterus. So a female with primary amenorrhea plus cyclical pain, the diagnosis is imperforate hymen or transverse vaginal septum, which lead to accumulation of blood within the uterus, that is known as hematometra. And the same lady with primary amenorrhea and her FSH, LH, and estrogen level are normal, will suspect absent uterus, and the ultrasound will show no uterus in the pelvic cavity. So primary amenorrhea with cyclical pain, diagnosis will be hematometra. Primary amenorrhea with normal FSH, LH, and estrogen, diagnosis will be absent uterus, which will be confirmed by doing an ultrasound, which will show no uterus in the pelvic cavity. Now, in Turner syndrome, remember that whenever there's a problem with the ovaries, estradiol or estrogen will be low. Remember this point. Whenever there is problem with the ovaries, estradiol or estrogen will be low, and FSH and LH will be high. So in Turner syndrome, as there are ovarian dysgenesis or ovarian failure due to one missing X chromosome,
Sir, we're not able to hear you properly again.
from the Turner syndrome topic.
I think it started way before that, but it got worse, much worse when you're talking about Turner syndrome.
I think then there is an issue with my internet connection. So we were discussing Turner syndrome. Guys, there's a problem with my internet connection, so please bear with me because I don't have any other option but to continue. So in Turner syndrome, I was telling you that whenever there's a problem with the ovaries, estrogen or estradiol will be low and FSH and LH will be high. Remember this point. So whenever you see these findings in the lab investigation, that is low estradiol or estrogen and high FSH and LH, then you will suspect that there is a problem with the ovaries. So a female with primary amenorrhea and lab investigation shows increase FSH and LH and decrease estradiol, then we will suspect Turner syndrome. What are the other features of Turner syndrome? The other features will be other features of Turner syndrome, the most important ones are short or webbed neck, short stature, and widely placed nipples. So a female with primary amenorrhea, short stature, short, short or webbed neck, and widely placed nipples, you will suspect Turner syndrome. In Turner syndrome, there is ovarian dysgenesis or ovarian failure, and the main function of the ovary is to form estrogen or estradiol. So on lab investigation, estrogen or estradiol will be low, and FSH and LH will be high. So I hope how to make a diagnosis of Turner syndrome is clear to everyone. So far, we
Yes.
have discussed three causes of primary amenorrhea: hematometra due to imperforate hymen or transverse vaginal septum. The second one was absent uterus, in which LH, FSH, and estrogen all will be normal. And then the fourth one is Turner syndrome or ovarian dysgenesis due to Turner syndrome. And the fifth one was congenital adrenal hyperplasia that we have discussed in the chapter of endocrinology. So can someone tell me what will be the presentation of a patient with congenital adrenal hyperplasia? Dr. Joe, can you tell us how a patient of congenital adrenal hyperplasia will present to us?
Sorry, I'm not sure about that, Dr. Shah.
So it will be amenorrhea.
Yes,
There will
menstrual
menstrual,
irregularities.
yeah, and there will be increased secretion of androgens that leads to hirsutism.
Yes, hirsutism, hair growth on face, chest, and back. That's right. So high androgen can lead to menstrual irregularities and hair growth in females. And the third thing that can high androgen can cause is acne. So acne, hirsutism, and menstrual irregularities. This is how congenital adrenal hyperplasia can present. Which other disease has a similar presentation?
PCO, polycystic ovarian disease.
Yes, polycystic ovarian syndrome or PCOS. So the difference between them is that in PCOS, the patient will be obese and her LH and FSH ratio will be double.
2:1, yeah.
Yes. So this was all about the causes of primary amenorrhea, hematometra, absent uterus, Turner
Excuse me, sir.
syndrome. Yes.
In PCOS, the LH and FSH ratio will be double as compared to CH.
Yes.
Okay.
CH, yes. There are two differences between them. In congenital adrenal hyperplasia, the patient is lean, and in PCOS, the patient is obese. And the other difference is that in PCOS, there's a typical lab finding, and that is LH is doubled than FSH. So LH FSH ratio is doubled. The ratio of LH to FSH is 2:1. Mean if the FSH is 10, then the LH will be 20. If FSH is 20, then LH will be 40.
Okay.
So whenever a female presents to you with amenorrhea, the first investigation that you need to do is beta HCG to rule out pregnancy. So if beta HCG is positive, then the amenorrhea is due to pregnancy. Then we do not need to do any other tests. But if beta HCG is negative, then we need to do TSH levels and prolactin levels. If prolactin levels are high, then it is most probably due to prolactinoma. The amenorrhea is most likely due to prolactinoma if prolactin levels are high. And if TSH levels are high or low, then the amenorrhea may be due to hypothyroidism or hyperthyroidism, depending upon the TSH value. So first test that we need to do is beta HCG. If beta HCG is negative, then prolactin level and TSH level. If they are normal, then we will go for other tests such as FSH, LH, and also we will perform an ultrasound. So before we discuss in details how the level of FSH, LH can be helpful in the diagnosis of amenorrhea, let's just discuss this diagram. So if you want to understand these topics about amenorrhea accurately, and then you need to understand this diagram very well. You need to remember three things, that is hypothalamus, pituitary gland, and ovary. Remember this axis and you will not get the questions that are related to amenorrhea. You will not get them wrong. So hypothalamus, pituitary, and ovarian axis. So what is this axis? We all know that we discussed in endocrinology that hypothalamus releases a hormone, that is GnRH, gonadotropin releasing hormone. Gonadotropin releasing hormone is released by the hypothalamus. It stimulates the pituitary gland to produce two hormones that are LH and FSH. So hypothalamus releases GnRH, which stimulates the production of FSH and LH from pituitary gland. FSH and LH then stimulates the ovarian cells, which are thecal cells and granulosa cells, to produce estrogen. So remember this axis, hypothalamus, pituitary, and ovarian axis. Hypothalamus releases GnRH, which stimulates pituitary to release LH and FSH. LH and FSH then stimulates ovary to produce estrogen. Then as this estrogen then exert a negative feedback mechanism on pituitary to decrease the production of LH and FSH. So whenever there is a problem with the hypothalamus or anterior pituitary gland, so if there is a problem with the hypothalamus, GnRH will not be released. So there will be no GnRH to stimulate the production of LH and FSH. So LH and FSH will be low. So if there's a problem in the hypothalamus or in the pituitary gland, LH and FSH will be low. So if LH and FSH are low, then you will suspect either a pituitary problem or a hypothalamus problem. Because of low LH and FSH, there will be no production of estrogen by the ovary, so estrogen will also be low. So in hypothalamus or in pituitary problems, LH, FSH, and estrogen, all three of them will be low. Is this point clear to everyone? In amenorrhea due to hypothalamus or pituitary gland, FSH, LH, and estrogen will be low. All three of them will be low. Now, whenever there is a problem with the ovary, Pituitary and hypothalamus both are normal. They are producing normal levels of LH or FSH, but there is a problem with the ovaries, such as polycystic ovaries or premature ovarian failure. So whenever there is a problem with the ovary, mean ovarian cells are not able to produce estrogen hormone. So estrogen will be low. Due to low estrogen level, this negative feedback mechanism will not be present. So low estrogen will stimulate FSH and LH release from the pituitary gland. So in ovarian problems, estrogen will be low and FSH and LH will be high. In short, we can say that if
Sir,
FSH and yes,
so how in hypothalamus pituitary problem the LH and FSH are low and also the estrogen is low?
because FSH and LH stimulates the secretion of production of estrogen from the ovary. So when there is no LH or FSH due to problem in the pituitary or hypothalamus, there will be no production of the estrogen. So in these problems, the low level of estrogen is due to low level of LH and FSH. But in ovarian problems, the low level of estrogen is due to problems in the ovary. So whenever the estrogen is low, high estrogen, remember that high estrogen inhibits the secretion of LH and FSH. But when ovary is not able to produce estrogen, then it leads to a positive feedback on the pituitary gland, and the body try to produce more estrogen by releasing more luteinizing and follicle stimulating hormone in an attempt to increase this estrogen level.
Dr. Shah,
Yes.
in problems with the hypothalamus and the pituitary, why don't we see a positive feedback due to the low levels of estrogen? The way we see with ovary problems, there's a positive feedback. How come the same doesn't happen with in the case
Yes,
of low estrogen?
in hypothalamus and pituitary, the estrogen level are low. It will stimulate the production, but you can see that there is problem with the pituitary. There is hypofunctioning of the pituitary. No matter if it stimulates the release of LH and FSH, it will not be able to produce it, because you can say that the pituitary gland is damaged. So how it can increase the production of LH or FSH? So
Okay,
it will be still will be low because the problem is in the pituitary. Is this point clear?
yes.
Yes.
So the pituitary or hypothalamus is diseased. It means all three will be low. There will be no production of LH or FSH even if there's a positive feedback of low estrogen, because they are damaged. Which condition can damage pituitary, or which condition can lead to hypothalamic failure? Hypothalamus, in which hypothalamus fail to produce GnRH. We will discuss those conditions one by one. So whenever there is problem in the ovary, and pituitary or hypothalamus are normal, so due to problems in the ovary, less estrogen will be produced, and it will stimulate the production of LH and FSH from the pituitary gland, because in this case the problem is in the ovary and the pituitary gland is normal. So this positive feedback will really lead to an increased production of LH and FSH. That's how we can differentiate if the problem is in the ovary or if the problem is in the pituitary. So in short, remember two lines. In pituitary or hypothalamus problem, FSH and LH will be low. So FSH and LH are low, then we'll suspect either a pituitary problem or a hypothalamus problem. And if they are high, LH and FSH are high, we'll suspect an ovarian problem such as polycystic ovarian syndrome or premature ovarian failure. Is it clear, everyone?
Yes.
So there's a question about the polycystic, like for example, if there is a low estrogen and it gives a feedback to the hypothalamus, sorry, to pituitary to release more luteinizing and follicle stimulating hormone. So why does it happen like that in polycystic? LH is double than FSH because it's the same stimulation. So is there any particular reason for that?
A particular reason for that is that you can see that detail in this diagram as well, and that I exempted or omitted on purpose
Right.
because I didn't want it to go into the details.
Okay, that's
That
fine.
is not required for the PEP one. But you can see that luteinizing hormone, they stimulate the thecal cells,
Mhm.
and follicle stimulating hormone, they stimulate the granulosa cells.
Right.
So thecal cell basically produce androstenedione. Androstenedione is an androgen.
Right.
This androgen is converted by aromatase enzyme that is released by the granulosa cells,
Right.
which convert this androgen into estrogen, which then lead to a negative feedback mechanism and inhibit the suppression of this. But in polycystic ovarian syndrome, the basic abnormality is a genetic defect.
Right.
Genetic defect which lead to excessive production of LH by the pituitary gland.
Mhm.
This excessive LH will produce excessive androgen such as androstenedione. So this excessive androgen will lead to the sign and symptoms of polycystic ovarian syndrome, because all of this androstenedione will not be converted by this aromatase enzyme into estrogen.
Right. Right.
So the basic abnormality in the polycystic ovarian syndrome is not less production of estrogen, because in polycystic ovarian syndrome, estrogen level are almost normal or even mildly increased.
Mhm.
The basic genetic defect in polycystic ovarian syndrome leads to excessive production of LH. This excessive production of LH is the main problem. This
Right.
excessive production of LH leads to an excessive production of androstenedione by the thecal cells.
Right.
So some of this androstenedione is converted into estrogen, but most of it remains in this form. So that's why there is excessive androgen in polycystic ovarian syndrome due to excessive LH.
Okay, that's fine. Thank you.
So in short, if FSH and LH are low, then where is the problem? In pituitary or in hypothalamus?
Did you?
How we can differentiate between pituitary and hypothalamic problems, that depends upon the history of the patient. In endocrinology, we discussed that hypothalamic failure can occur in athletes or due to excessive exercise or due to stress. So if an athlete present to you with amenorrhea and her LH and FSH level is low, then your diagnosis will be hypothalamic amenorrhea. While for pituitary amenorrhea, because both of them will have low levels of LH and FSH and also estradiol or estrogen, so we can differentiate between them on the basis of history. Hypothalamic amenorrhea will be asked in the Plab 1 exam, like an athlete or a female after exercise developed amenorrhea, or a female with bulimia nervosa who is not eating properly. All these things can lead to hypothalamic failure. while pituitary or hypopituitarism can occur in Sheehan syndrome and pituitary apoplexy. Or non-functioning pituitary adenoma can also lead to hypopituitarism. So the difference of hypopituitarism or pituitary amenorrhea will be on the basis of history. What is a Sheehan syndrome and what is pituitary apoplexy? We'll discuss it in a few minutes. For now, the point that I want to make clear is that if FSH and LH are low, then the problem is in the hypothalamus or in pituitary. If they are high, then the problem is in the ovaries. Is this point clear to everyone?
Yes.
Okay, now we discussed the causes of primary amenorrhea. Now we are going to discuss secondary amenorrhea. Secondary amenorrhea can occur due to hypothalamus failure, due to hypopituitarism, due to hypothyroidism. So you can remember these uh, endocrinal causes of secondary amenorrhea from top to bottom. Hypothalamus is on the top, so hypothalamic failure can lead to amenorrhea. Pituitary failure can also lead to amenorrhea. Then there is thyroid gland, hyper and hypothyroidism. Both of them can lead to amenorrhea. Then these were the causes that are above the ovaries. Now the problem with the ovaries: polycystic ovarian syndrome, post-pill amenorrhea, premature ovarian failure, and one of them prolactinoma that should also be counted in here in the pituitary amenorrhea. So prolactinoma can also cause amenorrhea. So 4 causes are due to glands that are above the ovary, such as hypothalamus, pituitary, thyroid, and uh, prolactinoma. And 3 causes are due to problems in the ovary, such as polycystic ovarian syndrome, post-pill amenorrhea, and premature ovarian failure. Even post-pill amenorrhea is due to problems in the pituitary gland, due to problems in the FSH and LH secretion. How that we will discuss in a few minutes. So now you can understand this table very easily. PCOS and premature ovarian failure, you can see that LH and FSH are high. In premature ovarian failure, FSH will be high, LH will also be high, but in premature ovarian failure, FSH is normally high than LH. And in PCO, LH are high and FSH is normal or high, but still half of LH, or more precisely, LH or FSH ratio is doubled. So LH will be double than FSH. And estrogen level are normal or mildly increase in PCOs. Because as I told you in this diagram that in PCOs, there is no problem with the estrogen production. So estrogen will be normal or mildly increased. The problem is due to high LH, which leads to a high synthesis of androgens such as androstenedione, which are converted by aromatase into estrogen. So estrogen level will be normal or mildly raised, but the problem will be due to high LH. Now in premature ovarian failure, because it's an ovarian failure and the function of the ovary is to produce estrogen. So when we say ovarian failure, then it means ovary failed to produce estrogen. That's why it is called ovarian failure, because the ovaries has failed to perform its normal function, and that is to produce estrogen. So estrogen will be low. Due to low estrogen, what will happen? A positive feedback on the pituitary, which will lead to high FSH and LH. Now, so the problems when the problem is in the ovary, such as PCOS and premature ovarian failure, FSH and LH will be high. For PCOS, remember specifically that LH levels will be double than the FSH levels, and due to which there will be normal or mildly increased estradiol. And also prolactin can also be mildly increased in PCOS. Normal value of prolactin is 400. In PCOS, the level of prolactin can be 5 to 600, mildly increased. Now, the problems that are in pituitary glands, such as prolactinoma or a Sheehan syndrome. What is a Sheehan syndrome? We will discuss it shortly. Pituitary apoplexy or hypothalamic failure, all of them will have a decreased level of FSH, LH, and estradiol. So, is this table clear to everyone?
So can you move the table a little bit down? That's it.
Just simply remember that when the problem is in the ovary, LH and FSH will be high. When the problem is in the pituitary or hypothalamus, LH and FSH will be low. And estrogen will be low as well. Because of low levels of LH and FSH, that stimulates the production of estrogen or estradiol. So I hope this table is clear to everyone. If there is any question, you can ask. So we discuss how a patient of hypothalamic amenorrhea will present. In the history of hypothalamic amenorrhea, it will be mentioned that the patient is an athlete or a marathon runner, or after excessive exercise, she has developed amenorrhea. These will be the hints towards hypothalamic amenorrhea. In lab investigation, because the problem is in the hypothalamus, LH, FSH, and estradiol all will be low. Now, how a patient of pituitary amenorrhea will present? Pituitary amenorrhea will